Thank you, Dr. Momita Ray. It was an excellent moderated session. Thank you to all the speakers and the chairperson and all the participants for making it interactive. So now I would like to take over for the next session. Satabdi, are you there? Yes, you are there. Fine. Satabdi, we cannot hear you.
Yes. Am I audible now?
If you are audible, you are visible perfectly.
Okay, thank you. Very good morning and good afternoon to everybody. Now we are going to have a very wonderful session, and that will for that session we are going to be enriched by our respected speaker, Dr. Reda Satki. He is there, who is the founder president of Geneva Learning Foundation. And for this session, we have two of our very respected chairpersons. Let me get some time to share my screen. Is it visible?
It's visible. It's visible. Please make full screen.
Okay.
It is visible. Please make full screen.
Yes, it is now full screen. Is it okay, sir?
It is okay.
Okay, you're Satabdi. Okay.
Okay.
Am I audible and visible?
Yes, sir. Clear and loud, sir.
Satabdi, please.
Yes, sir. We are here honored to request Professor Dr. Rabindranath Sinha, sir. He is PCH, MD, and PSM. Professor R.N. Sinha, sir, is presently Director Professor of Public Health in All India Institute of Hygiene and Public Health in Kolkata. He has more than 25 years of experience of undergraduate and post-graduation teaching in community medicine or public health. Sir has working experience of leading public health activities of community health centers starting from rural Bengal and as the research senior fellow in the Division of Epidemiology of Indian Council of Medical Research, National Institute of the Cholera and Enteric Diseases, NICET, in Kolkata, West Bengal. As investigator or co-investigator or research person, sir has participated in a large number of community-based surveys, research studies, and training programs in collaboration with various prestigious organizations like World Health Organization, UNICEF, NSCO, NPCP, ICMR, IPHE, Government of India, Incline International, etc. Sir has more than 30 publications in different national and international journals, including contribution of 2 chapters in multi-author textbooks of community and social pediatrics. He is fellow of Indian Public Health Association and currently he is the associate editor of Indian Journal of Public Health, IGPH, and chief editor of Journal of Comprehensive Health, JCH, published by Indian Association of Preventive and Social Medicine. We are now honored to invite our second chairperson, Dr. Pramit Ghosh. Dr. Pramit Ghosh, sir, is an eminent public health professional. He has been involved with various multidisciplinary research and capacity building activities in the fields of RMN-CHA, HIV/AIDS, RTI/STI, leprosy or silicosis, immunization, and recently COVID-19 disease modeling, etc., with different stakeholders, including UNICEF. Dr. Ghosh has participated in effective vaccine management and AEFI investigations at state and national level. After 15 years of working in the medical education service, he has moved to ICMR RMRC Dibrugarh about 3 months back. Now we are going to introduce the person who is going to enrich us with a new thing, with an innovative thing. That is the Immunization Agenda 2030, Dr. Reda Satke. He is the chief executive with lifelong experience in forging multidisciplinary teams to invent and execute new ways to lead change. He is the founder and president of Geneva Learning Foundation and chief learning officer of Learning Strategies International. Reda has worked for the United Nations, primarily for the World Health Organization and at the International Federation of Red Cross and Red Crescent Societies. Over a decade ago, yes, now we explore how to transform digital learning. For the Red Cross and Red Crescent, 13 million volunteers and 5 lakh staff in 190 countries. Starting in 2016, Reda led the development of what had become, by January 2019, the world's largest and fastest growing digital health framework of immunization professionals.
Please mute your mics.
Homie Roy.
Please mute yourselves. When the COVID-19 pandemic hit, this digital health infrastructure enabled the development of COVID-19 Peer Hub. And I was honored to be the part of this Peer Hub, and I have worked under Dr. Reda. And the aim of this Peer Hub to support rapid response and collaboration across health system levels. Attendance, please mute yourself.
Oh, sorry. Mute yourself.
Ribu, can you please intervene? There are disturbances. Ribu, please.
If Nishita, please mute Homie Roy. Nishita, please mute Homie Roy.
The aim of the COVID-19 PR Hub is to support rapid response and collaboration across all system levels and borders by professionals to mitigate the shock of the pandemic on immunization services, to respond to the root causes of vaccine hesitancy, and to strengthen resilience for the service recovery. Reda's vision today is that the COVID-19 pandemic has created an opportunity for a digital-first renaissance in global health. He believes that the next 20 years of public health are likely to be about harnessing digital transformation through hybrid networks, fusing digital as well as physical in ways that can help not only deliver knowledge, not only deliver health, but actually transform health outcomes. Learning how to develop people by digital means a vital investment for the promise of digital health to be realized. And now I am requesting our respected chairpersons to take the opportunity to continue the session. Thank you.
Thank you, Dr. Shatabdi. May I start? Shatabdi, you please.
Yes, sir.
See your PowerPoint. Sir, this is my proud privilege to invite Dr. Reda Sadgi, the founder and president of Geneva Learning Foundation and chief learning officer of Learning Strategies International, who strongly believes that COVID pandemic has provided an unique opportunity for digital first renaissance in global health. Thank you, sir. Thank you for accepting our invitation to share your views and thoughts on Immunization Agenda 2030, how digital health networks for primary healthcare can help build a global movement to accelerate progress towards global goals. Sir, my learned co-chairperson, Dr. Promit Ghosh, from Indian Council of Medical Research, he's a senior scientist there, has long years of experience of assisting West Bengal state government in effective vaccine management and monitoring quality of immunization services in the state. He knows very well the various challenges, including implementation challenges to conform to the Immunization Agenda 2030 in our state. Maybe after your deliberation, he may share his thoughts and experiences in the field also. Sir, our members are eagerly waiting to hear from you. You are most welcome, sir. Please continue, sir. Please share your views. Shatabdi, please arrange.
Yes, sir.
All right. Thank you very much indeed. So I will be sharing from my webcam. So if you double click on my little thumbnail where you see my name, you should be able to see the slides full screen. First of all, I'm Reda Sadgi. I'm the president of the Geneva Learning Foundation, and I'm honored by this invitation. We run global learning initiatives and have many participants from India in these initiatives who distinguish themselves through their performance. We know that in the last 2 years, of course, because of the pandemic, many of us have been forced to move online. The Geneva Learning Foundation has been working by purely digital means since its creation in 2016. And what we like to do is we like to add some emotion to the presentations that we do. So it may be unusual in the context of a scientific society's formal session to hear music in the background, but that is how I am going to kick off, if you will. First of all, the highlight, I'm connecting from Geneva, Switzerland. So you can see here the trip I would have had to make in the physical world to come to West Bengal and attend in person. I will be speaking about the new digital economy of effort and what that actually means. But I think this makes an obvious point, which we're all now familiar with, but we still have a long ways to go, literally and figuratively, to fully harness what it means that I can be connected to you while it's here 7:30 a.m. in Geneva, Switzerland, and while you are gathering presumably people from the entire region through this through the digital medium. Just a personal note, for anyone who would like to know more about our work, you can see on the left-hand side my Twitter and LinkedIn profiles. You just look for my name, and on the right-hand side for the Geneva Learning Foundation, I will point you to the resources on our YouTube channel as well as our Facebook. Now, just to kick off, I'm going to get to and speak to Immunization Agenda 2030. But before I do, I'm going to invite you to embark with me on what has been my journey, a very personal journey, exploring the digital transformation and seeking to understand how to best harness it for the purpose of education, and specifically of education as a philosophy for change. So you see here on the left-hand side the course announcement from the very first pilot we did with the World Health Organization in 2016 on the GRISP, the Global Routine Immunization Strategies and Practices Guidelines. And guidelines very often sit on shelves or now on websites or hard or disks We wanted to find a way to break out of that and to put the best available global knowledge from WHO into the hands of country-based practitioners. Since then, you can see on the right-hand side, we've developed, I think we've now done 30 cohorts with WHO, as well as a number of initiatives that we have led independently, working closely with ministries of health and country-based practitioners. What this has led to is the world's largest platform of country-based immunization professionals connected through the Geneva Learning Foundation, but also connected to each other. And that is a very important point in today's hyper-connected world, that this is not only about us from Geneva sending out information, however relevant and useful it may be. It is also about supporting health professionals and making connections to each other. Today, we offer a full package of interventions focused on global health and immunization, really looking at that entire continuum from knowledge acquisition, when you pick up a piece of information, to the ideas that this can generate, to the practices that this can lead to the action planning, the implementation, all the way to, in the context of global health, to the point of actually being able to document and measure an impact on health outcomes. Now, that's in a nutshell. Well, what I'm going to do is take you through quite a intricate journey to help you understand the theoretical and pedagogical underpinning of what has led us now to state very publicly that we believe that for the world to achieve the goals of Immunization Agenda 2030, we're going to need a different approach, and we're going to need to fully leverage that digital economy of effort. So when considering what to us is a key question, really, Immunization Agenda 2030, or IA 2030, of course, there is a technical dimension and there is a website dedicated to that. I'm going to look at, in a way, what may seem a bit incongruous for a room of technical specialists, but I'm going to invite you to consider the emotional dimension. If you work in immunization, whether you're the vaccinator at the most local level, where vaccination actually happens, or whether you're a planner in the Ministry of Health at the central level, Immunization Agenda, the world strategy for the entire decade, challenges you to really answer this question. Now, as an educator, I'm concerned these days with answering questions like these about the future of learning. And I tend to be, in general, very cautious about playing the soothsayer, and I'll show you why. I'll run through these quickly. You can find them online. They're kind of fun to consider. But here are some of the, let's say, the poor predictions about the future. This is 1876. This telephone has too many shortcomings to be seriously considered as a means of communication. The device is inherently of no value to us. This is Sir William Preece in 1876. Americans have no need of the telephone, but we do not. Why? We have plenty of messenger boys. In the 1920s, wireless music box, no commercial value. This is, of course, talking about radio. Recording company rejecting the Beatles. Drill for oil? You're crazy. What purpose could that possibly serve? Who wants to hear actors talk? And this is H.M. Warner from Warner Brothers. While theoretically and technically television may be feasible, commercially and financially, it is an impossibility. And this is 1968. Japanese auto industry isn't likely to carve out a big slice of the US market. And this is about data processing. And my favorite one, number one in the countdown, is there's no reason anyone would want a computer in their home. And of course, this is a now defunct, the CEO of a now defunct IT corporation. Now, these examples may seem to be far removed from global health, but I hope the word of caution as we explore the future of immunization, as we explore the future of health, of digital health education, we want to be very modest, and I will try to do so in the claims we make. Now, a personal note, because you may not know me. this is meet with my with the rest of the family, and I've spent the last almost 30 years exploring new ways to do new things. Pretty much everything I have done over the course of my career has been to do things that were not being taught anywhere when I learned to do them. So figuring out how to do things when there is no instruction manual has been part and parcel of my my journey, and what led me to the complex challenges of global health. A key piece of what I became interested in and what we believe is essential to consider when thinking about global health, when thinking about the design of immunization programs and how we develop people who are going to need to function within what we design, are these two questions. Or one is a question, what can we afford to do? But as a statement, it is also powerful and compelling. And I hope you'll see why as we progress through the presentation. So what can we afford to do and what we can afford to do? The way I became confronted by this question, I was summoned by an Undersecretary General at the International Federation of Red Cross and Red Crescent Societies. And he said to me, Reza, can you help me bring the Red Cross into the 21st century? So I said, yes, sir. Where do we start? And he gave me the management responsibility for a broken learning management system. And he said, you figure out how to meet the learning needs of the 13.1 million active community-based volunteers in 189 countries working in the Red Cross and Red Crescent throughout the world. He then said, you have 100,000 Swiss francs and you have 4 people, you do not get to choose who they are. So this is how I began my journey exploring what learning at scale means. And after the IFRC created the Geneva Learning Foundation, interested in 5 specific kinds of organizational problems that you can see here. How do we move from strategy? Organizations are great at coming up with strategies, but how do we move to implementation? How do we put reporting practice to use when we collect data, when we share knowledge? How do we document experience in the face of the unknown? For example, during the COVID pandemic, how do we quickly enough collect what doctors, nurses, health workers are learning from each other, are learning together on the front lines, so that, and share it throughout a network so that everyone can benefit from what is learned? Fostering collaboration across silos, for those of you who work in bureaucratic structures, should be maybe a familiar challenge. And then when we have those guidelines, the world's best available knowledge sitting on the shelf, how can we bring that to life? We came with, and this is the first piece of evidence that I think every health professional needs to be familiar with, and it is the evidence comparing online learning versus face-to-face learning versus blended learning. And so in response, these are the 2 most comprehensive meta-analyses done a little bit over a decade ago, comparing and exploring everything we know about these. And since 1991, it turns out that distance learning results in increasingly better learning outcomes than face-to-face. And if you think about distance learning in 1991, far more rudimentary technology to support effective learning across distance than what we have now. And even then, we still had better learning outcomes. Many people will say then, well, what's ideal is if we can blend, we'll do something online, some things face-to-face. It turns out that there's no positive effect associated with learning per se. The main difference tends to be that that learning, people will typically work online, and another time face-to-face. Now, creating the Foundation, we were led by the visions of a number of educational thought leaders working at the global level. One of them is Karen Watkins, and thinking about that question of impact, thinking about what this means in health education, whether we're talking about pre-service or in-service training. The idea that education can lead to impact is a compelling one. Where we started was with 3 initiatives: the Digital Scholar, Ambulance, and then the immunization story, which I will tell fully and which leads directly to Immunization Agenda 2030. So for Digital Scholar, this was teaching the core pedagogical principles and practice that we found made for effective learning systems that are fully digital and can actually support not just learning, but beyond learning outcomes, lead to actual change. And one example of how this program led to change for Nadine Canning is that since taking this program, she had been previously a completely face-to-face trainer, very much committed to the training room. And 3 years after taking the program, she was in charge of digital learning and education in a startup. Now, our very first project was with the Norwegian Red Cross, the IFRC, and the IFRC under the Healthcare in Danger project, focused on the threat of violence against health workers, and specifically pre-hospital emergency health workers. Within 3 months, we knew nothing about this topic, had no prior experience. Within 3 months, we had built a community of over 5,000 pre-hospital emergency hospital practitioners. And one of the surprising outcomes that we observed at the time, and that became a guiding light or principle for our foray into immunization, was this. Cristina Guerrero leads a helicopter rescue team. She's a highly qualified medical emergency doctor, and she has seen it all in the emergency context. But the ability that our program gave her to connect with ambulance workers across the world, ambulance professionals, ambulance volunteers in Syria, for example, or in other places where ambulance personnel face great danger, led her to reconsider how she thought about the threats of violence that she faced every day. And she said what was surprising in a digital initiative was that she said, I became mindful in new ways. And typically people think, okay, well, online you can sort of give people information. And what we found that we could do so much more. And I'd like to invite those of you that are being forced to work through Zoom or Teams or whatever the tools may be, to consider, are there things that you could do that you're not currently doing? And I hope the examples I'll share in this session will be helpful to that respect. Now, when it came to immunization, as I said, we started with the first pilot in June 2016, have built now dozens of cohorts since, and built also a theory of change of how we could teach people how to learn to connect for those that did not already know. I can think of a grandmother from Central African Republic who used Skype for the first time in our course, and following that created a WhatsApp group connecting 3 generations of her relatives, of her family for the first time. And she had never used social media before our program. So teaching those digital skills is very, very much central to what we do. Helping people figure out how to harness those technologies. Connecting to learn then is the second step, and really connecting to learn as connecting humans to humans, encouraging, finding ways for people to support each other, to engage in deep collaboration and reflection across distance. And then most important is really the action component, is really how we use that ability to learn to connect in order to do things together in new ways that can lead to impact. So by January 2019, the network was around 15,000 strong and growing fast. We did the first program impact evaluation, and this was the conclusion. These are more than just courses. These are interventions designed to foster and improve practice at every level. We found that scholars, as we call participants, learners in our programs, reported extraordinary high levels of use of what they gained from the program. So typically knowledge transfer, when you learn something in a course, people tend to transfer back to work less than 10%. We saw far higher percentages that exceeded our own expectations. Second, scholars who implemented projects they developed in a course actually were able to document increase in immunization coverage. Won't go into the details here, but that was one of the takeaways, and this was in January 2019, so obviously pre-COVID. Third results that startled us is that the peer learning built into the courses led to the emergence of country-based groupings where our alumni decided to congregate, to come together, create groups, meet on a regular basis, and lead and support each other in taking forward the projects that they had grown in our courses. Now, I'm not going to go too much into the pedagogy of this because I do want to get to Immunization Agenda 2030, but you can see here the old learning model is the teacher is in the center transmitting information to the students. The new learning is a kind of hub and spoke model where everyone is connected to everyone else. And the teacher becomes a facilitator. In some cases, learners become teachers and teachers become learners. And you can see here on the right, the new learning model from Bill Cope and Mary Coulancis, two of the founders of the Geneva Learning Foundation, who helped create and guide and strengthen the theoretical underpinning. Learning ecology is another way of looking at what we do and how we do it. And you can see here there is a lot going on. There's even more here in Karen Watkins, another one of our founders' model for learning culture, looking at what is the relationship between learning culture, the ability to change, to innovate, to consider new things and figure out how they fit in. And then there is connectivism, which comes from another one of our co-founders, George Siemens. And this one is about saying that the ability that we have to connect to each other, I'll come back to that in a little bit, is actually more important than what we know at any one particular time. But without going into any of these frameworks in further depth, it's also that in order to go from a framework to a practice, we relied on bringing together an amazing set of individuals, talented individuals who learn to work together in what we call the scholar team. This is a team from previous years, but we obviously have a team, an amazing team now. And our vision for education, and I'd like to invite you to consider these 4 quadrants. We typically think about knowledge acquisition, so the competency development when we speak about training, for example, in-service training. But there is so much more, and that includes the most powerful forms of education are ones that are experienced as a personal transformation. It is not only about developing competencies, it is about making sure that you gain cognitive and employable skills through the learning. And then last but not least is the access to opportunities. Very often the formal qualification is a signal of aptitude. It's a credential that is accepted in the marketplace. It's also a network of affiliates, peers who have the same qualification or the same status professionally. And we hope to provide all these things through purely digital scholar programs. So we are not there yet, but that is certainly the journey we are on. Now, what we realized from all these frameworks, from all of this complexity, was something very simple. Is that when we boiled it all down and we worked for months with a group of our alumni to understand what would actually be most helpful to them, to take the education, to take the knowledge, to take the action plans that they had developed. And we asked a simple question: are you ready to take action? You developed an action plan using the world's best available knowledge, as well as what you know that others do not know about your local context. And so in July 2019, for the first time, 644 scholars from 55 countries signed a pledge that they would work together to achieve impact. Now, this Impact Accelerator has 4 pillars: pledge, measure, share, and mobilize. And again, was rested on this theory of change, supporting the development of digital skills, helping people, fostering connections between individuals in order to support them working together. Now, what this led to is from a digital, purely digital initiative, alumni began to meet in physical spaces in their own countries. And you can see this set of countries, this set of photos is from meetings that took place in July 2019 in West and Central Africa. And you can see here people began to use, and remember most of these individuals, most of the participants are civil servants working for the Ministry of Health expanded program on immunization. And they are doing this, they are meeting this time on their own time, I would say also on their own dime, because they want to, because out of the experience that they have had of connecting to each other, they have decided that they want to go further together. In Nigeria, for example, the scholars were disappointed when they discovered the quality of the data improvement plan that had been submitted by their Ministry of Health. They decided to help and to meet together to figure out how they could improve that data improvement plan. Now, there are different aspects of the accelerator. You can see the ones that were reported by participants as being most valuable. You can see that through the accelerator, if you imagine this web of individuals within their own countries sharing information, supporting each other, and across countries, and a group that is coming from all system levels, coming from everywhere. The point at the end of the day is about mobilization. It's about motivation. If you look at every study on health worker performance, there are two things. There are the technical skills, and then there's the motivation. And on the technical skills, we believe that simply throwing more content, giving more information is not sufficient, is unlikely to lead to improvements. On the motivation, people tend to throw their hands up in the air. It is the poor salaries or the unpaid salaries. It is the lack of resources more generally. What can we possibly do? Well, we found that there's a lot that can be done, and that people will find motivation in their mission, in their purpose, and in being connected to each other, sharing each other's successes, lessons learned, and challenges can be a very powerful way to solve both parts of that equation, provide opportunities to develop the best technical skills using the best available knowledge, the best available global expertise, and then also connect to each other in order to support and motivate each other. What we realized what we had built was a kind of human knowledge work, uniting alumni, united because they had all been through a performance-based program. So you do not finish, you do not earn a certificate for attendance, you earn a certificate through the effort that you invest. And so, of course, if you work in global health, you will ask, okay, so what? So this shows over a period of 6 months how people in a cohort, in that initial cohort, went from not having even started working on their action plan. So they had developed something, but an action plan is just intent. It says, I'm going to do something and I hope to achieve this goal. You can see the proportion in yellow of people who've actually started. And then starting at the third week, let's say, you actually have people within 6 months who are implementing and completing implementation of the action plan that they had defined in the beginning. So what we are doing is exploring new ways for countries and people who deliver vaccines in countries to lead change. Now, this was in 2019, and at the time, I remember being involved in some of the early discussions about Immunization Agenda 2030, and I could already begin to see how what we were doing, people connecting directly with people who deliver vaccines connecting to each other, could potentially be linked to what the architects of Immunization Agenda were doing, were saying, which was, we'd like to listen to what is happening at the local level. We want to have a different kind of global conversation. Now, this led in March to June 2020 to the, for Sanjay Sadukan, if you can double click on my name and shift to the speaker view, you should be able to see me much better. To see the slides much better than you can here. So between March and June 2020, so this is when the pandemic hits, with very little impact for the program because it is already fully digital. By June, 989 have earned level 1 certification in Teach to Reach, which is about improving immunization training. So teaching the core the core expertise of the foundation to immunization staff, adapting it to the needs of immunization professionals. Now, this is a second occasion to talk about what education has to do with immunization, with primary healthcare, and with medical education, medical and public health education more generally. So we can look at history. And this is lighting maybe, 200 years ago. This is lighting now. This is medicine maybe 150 years ago, and this is a form of medicine now. This is transportation before, and transportation now or tomorrow, but in the near future. This may be hard to imagine what this could possibly be, but this is actually what Silicon Valley looked like 100 years ago. This is communication then and communication now. And then, of course, there's something that continues to startle me. This is education 200 years ago, and this is education now. So it looks like the kinds of transformation that has happened in other industries, in other areas of work, has not happened to education. But then if you look at, this is a newsroom from the Atlanta Journal-Constitution in the United States in 1993. The Atlanta Journal-Constitution no longer exists. They did not know what was coming. And so there's some hard questions to ask about what is changing in education, and specifically in public health and medical education, that are worth considering. Now, many people get very excited referring to thinking about digital transformation, say what happened to the record industry, the music industry, where the MP3 format and its the ability to replicate in digital formats led to the growth of something called Napster and completely changed the music industry. We do not think it is that simple. That's for education, and here is why. This is from Bill Cope and Mary Kalantzis, and this is about education as the science of learning. Its subject is how people come to know. It teaches what has been learned and can be learned using these methods. And so in this sense, education, we can think about it as the science of sciences, and how education changes because it is of something is going to be different than any other science in many different ways. Now, when we conjure up, what does digital learning look like? Here is an image, I believe, from the 19th century. You can see the books going in, someone turning the, and then children receiving education. This view has deep roots. You can see this is a 1999 movie called The Matrix. And this is he's choosing the curriculum that Neo, the main character, is going to receive. And here is the particular, I think it's martial arts that he's learning. Plugs directly into his brain, and within a few seconds, he knows. So there's been a long running debate about whether this is a dream come true or a nightmare. And one can have an opinion either way. But these kinds of changes, the kinds of changes that are actually happening, can lead to completely new, different ways of learning than what you see in the 19th century vision and in the vision from the 1999 movie. We've tried to lay out what that vision for new learning and assessment that underpins the work that we do, that is not simply a sort of nice way to learn, collaborative, flexible, motivating, participatory, but is actually the way of learning that actually corresponds to the needs of today and tomorrow. Now, there's a lot of opposition between digital and physical, and I'd like to introduce the concept of what we call digital dualism. So this is a young man called Nathan Jurgensen. He's actually the resident philosopher at a company called Snapchat. If you have teenage children, I don't know if Snapchat is very much in use in India, but it is a way of sending messages that then disappear. Now, he actually is one of the most profound thinkers that I know of today about the relationship between digital and physical. And this is from a 2012 article where he already could see that if we pretend that digital and physical are separate, that only the physical world is in real life, that neglects the fact that we increasingly live in a world where everything is fused together. We will be on WhatsApp while we're having a conversation in the physical world. We'll be interacting over this Zoom call, as some of you are listening, others are have moved on to doing other things. That interaction is very much real life, and that is a way out of this digital dualism in which many of us get stuck when trying to think of what can we do with online learning, what can we do across distance, challenging, defying distance, as we learn to, when we need to work together, when we need to achieve public health goals in particular. Now, this view of the limitation of digital actually has its roots in the Platonic view of the world, because the original sort of formulation in comes that traditional negative view of the written word, saying that writing is an imitation of speech, and speech itself is an imitation of thought, and sort of reifying thought itself as being better, superior to the other forms, the other media, is something that is deeply rooted in our cultures, and that is something we have to consider. And yet, the evidence, to share it again, says something quite different. Now, many of us, I consider myself amongst the group of people who have been advocating for the effective use of technology for learning. And I believe that we completely failed at achieving our goals, that learning technologies are obsolete for a very simple reason, is that while we were busy trying to figure out how to do e-learning courses or how to convince people to use digital learning, there was a much deeper and broad, profound tidal wave of change through the digital transformation that just spilled over our societies. And our lives, our cultures are permeated by digital, whether we like it or not, whether we experience it as something that is a negative, or whether we harness the new possibilities that it creates. And that has impacted education in many ways. It's happened naturally, which means once it's embedded in the culture, the teacher will start using Skype or WhatsApp because that's what they do every day. So it is no longer unusual. It no longer requires thought or intent, but actually it does. We believe that there are significant benefits from taking a step back, reviewing how we use technology already in our education, in our public health work, and how we can best use it remains very important. And there's also something, we're in the midst of a fourth industrial revolution. Some people call it the second machine age, with the rise of artificial intelligence, with new technologies like CRISPR completely changing the biological as well as the physical and digital worlds. And so the relevance of education can't just be about using Zoom to do a lecture or using Zoom to work with a group of students. There are at least 5 things that are changing, and changing very quickly. Well, first, here to illustrate the first on performance, this is Kermit Washington. In 1987, he was good enough to get into the National Basketball Association in the United States, but his performance then faltered. His coach took him out. At the time, it was assumed that if you were good at what you did, you were just naturally good and you did not need to train. His coach saw it differently, took him out, trained him intensively for the summer, and he became an all-star player in the National Basketball Association. The relevant question, this is what we call the performance revolution, recognizing that performance in individuals, whether it's health professionals or basketball players, can be developed. That someone who looks like he's never going to be any good, actually through the right interventions can blossom into someone whose capabilities grow constantly, who is constantly learning, and who is constantly doing better in order to contribute to the team, the organization, the mission that they have. This is kind of the ideal performance. This is how we would like all of our teams to work, right? We would like all of our teams to achieve this level of performance, and that requires that performance revolution. The second thing that is changing very fast is scale and access. Obviously, through digital, we can provide access and we can reach way more people. The question is, do we use that scale and access to replicate the methods whose efficacy in a physical space has already been shown to be quite limited, or do we use it to do more and go further? Next thing that is changing is the nature of expertise. Expertise used to be organized in pyramids. That is no longer the case. Sometimes the best idea, the best practice can come from anyone, anywhere in the pyramid. So we need learning systems that can recognize that reality and adapt to it and enable anyone, anywhere who has a good idea, who has a good practice, to share it across a network and for that to be integrated into the learning and teaching. Applicability is the other thing that is changing. In the past, we knew that someone who went to a training room for 5 days and had to stop work in order to attend that training would struggle once back at work to figure out how to apply what they had learned. That's what we call the applicability dilemma. Believe new systems, new learning systems need to focus far more on applicability, on learning by doing, on project and problem-based learning than on knowledge acquisition. Diversity is another challenge. What do you do when every situation is different, when you are connecting people who are all working in completely different local contexts? We need learning systems that can address those challenges, and that is what we have tried to do through our work. Last is an example about complexity. So there's a famous study from 1998 called the Self-Designing High Reliability Organization. And this is about aircraft carriers in the United States. And there is no instruction manual for an aircraft carrier. It is simply too complex. And yet, what the researchers found is that it is a highly reliable organization and highly performing organizations, despite constant job rotations. Everyone in the aircraft carrier changes to a completely new job every 12 to 18 months. No two aircraft carriers are the same. And again, there is no manual. So where this gives us hope is that if you work in a messy world where you don't have everything you need, where things are changing constantly, some people in the military have called that VUCA, volatile, ambiguous, complex, uncertain environments. There are ways to organize learning in order to drive performance. And if it can be done by the military on an aircraft carrier, we need to figure out how to do it in our areas of work. What has changed is the nature of knowledge itself. There is an increasingly fast flow of knowledge. And what do you do when there's too much information? This starts on a very personal level with our inbox in email. Each of us has developed strategies, but these strategies are not being taught anywhere. There is no one accepted way. This is how you deal with your inbox. And it's, of course, much broader than that. It's all of our societies are just inundated by too much knowledge, some of us feel. And we experience that feeling because we're still thinking of knowledge as a product when it has become a process, when knowledge is no longer to be captured in reservoir, but dipped into as a river where you need to be able to get what you need, when you need it, where you need it. This is a study that's been running since 1986 by Robert Kelly at Carnegie Mellon. And in 1986, if you were a knowledge worker, 75% of what you needed to know was right there in your brain. By 2006, that had fallen to 10%. So most of what you need to know in order to do your job is going to come from connecting with other humans and connecting with machines. So that is something that fundamental, that a learning system that does not take these considerations into account is unlikely to produce the results that are needed or to meet the demand for learning and change that in any particular context. Some of the humanitarian health crises have illustrated that. This is Anna Patrick commenting in The Lancet in 2015 that the lesson about the Ebola crisis response in 2013, 2014 was that building new treatment centers, so the physical infrastructure, was an easy task next to training and supervising people to staff them. So this is how we come to COVID. And that leads to Immunization Agenda. In April 2020, we organized the first online meeting. We call it a global assembly to invite the health professionals, immunization professionals in our platform to come together. And we ask, what can we do with this remarkable network? And this is where the assembled professionals developed, co-designed what grew into the COVID-19 Peer Hub. We referred back to the Pledge for Impact from the Impact Accelerator. And within a few weeks, by the end of June, there are more than 5,000 immunization professionals who'd connected specifically, who'd signed up, who'd committed to working on responding to the pandemic and the consequences it was having on immunization services. There were 80 million children at risk from vaccine-presentable diseases suddenly because of fear of caregivers, fear of health by health professionals about the pandemic, and of course, misinformation, disinformation, and so on. Most of the people who joined were Ministry of Health national and subnational level staff. The critical challenges we were able to identify had to do with, first and foremost, caregivers being reluctant to come to health facilities. So this is in June, July 2020. We asked, why would you join an initiative like this one? And here you can see this individual from Pakistan who explains how joining a digital network for the purpose of health can help expand her network across the immunization space. Another person from Ghana, halfway across the world, this broadens my vision and helps me be more imaginative, creative. First thing we did was called the Ideas Engine. So we set up a platform where immunization professionals could share ideas and practices around 7 key themes. Within 10 days, we had more than 1,200 ideas and practices shared, and these were then crowdsourced, where every participant could then give feedback and share what they thought of the idea and if they had anything similar, and so on. The challenges, we were able to sort of quantify also what were the most significant challenges being faced by health professionals. And here we have a consultant who works at the subnational level in Indonesia, who explains what was the point for her and what was the benefit. This being able to tap into these ideas actually led to the avoidance of vaccine wastage. And when we looked at where the ideas and practices were being used, here you see ideas from Ghana that are being used in Nigeria, in Ghana, but also India, Pakistan, Bangladesh, Kenya. So both a neighboring country, but also professionals halfway across the world who are tapping into the good ideas and practices of people in Ghana. And we could do this mapping for every country, but there's another dimension, which is that typically health systems are organized in pyramids from the central level to the most local levels. We believe there's much to be gained from the sharing of ideas across these levels of the health system. So we're able to actually map how people who develop projects working at the national level, so in the Ministry of Health in the capital city, actually found ideas from districts, health facilities, and other subnational levels that they were able to incorporate into their national planning. This would not happen without having a digital health network in place to do that sharing, or would be much less likely to happen. So when we asked people, what did you gain from the first exercise, which was focused on recovery of immunization services? It's amazing that a lot of people from different geographical backgrounds are doing so much under the cloud of COVID-19 to keep EPI services going. There was the technical knowledge, the ideas and practices, but pay attention to that last sentence. I am motivated greatly to do more. When we look at that equation, 2 factors go into health professional performance: technical knowledge, technical skills, competencies, behaviors, and motivation. And here we have a system that achieves both. You're sharing technical knowledge, ideas, practices that you would not have access to otherwise. You're also sharing successes, lessons learned, challenges, and that can motivate you greatly to do more. That was an amazing discovery for us. We then focused on that most critical challenge of vaccine hesitancy. And within 4 weeks, 720 this community, the COVID-19 Peer Hub, had developed 720 case studies and peer-reviewed them. And this is where we began to engage experts, global experts like Professor Heidi Larson from the London School and the Vaccine Confidence Project, or Dr. Anne Lindstrom from the headquarters of WHO, who was tasked with leading COVID-19 vaccine introduction and very much concerned about vaccine hesitancy. So we strive to go beyond the presentation webinar. We organized in the year of COVID over 200 live events we saw across our social media platforms. Audience of peers, of health professionals listening and contributing grew by 1,000%. And we believe this was the result of listening, first and foremost, paying attention to the needs of health professionals and helping them not only connect with us, the Geneva Learning Foundation, but helping them connect with each other. So again, we came back to that. We began to map out the continuum from knowledge to impact that we had developed, and did it, of course, in both languages. This is the French version of the COVID-19 Peer Hub. This is a quick summary of what this network was able to do specifically around COVID. But we realized that health professionals had to work on COVID-19 response, recovery, and then vaccination, but also were very much involved in other issues across the primary healthcare spectrum that includes vaccination. So we then asked this question: what can we do together to accelerate progress towards protecting children and adults from vaccine-preventable diseases? We built this capability, this kind of infrastructure, digital health education infrastructure to support learning and change. A human knowledge network, first and foremost, and we asked, what can we do together? So we saw things, people in the network began to answer the questions for themselves. There were a series of inter-country exchanges where COVID-19 Peer Hub members or country teams began to meet with each other to share rapid learning about COVID-19 vaccine introduction. This is the one from connecting Cameroon and the DRC. We invited participants and continue to invite every member in the platform to share success stories, lessons learned, and challenges so that they can be shared with everyone else. And then what we call the Knowledge Transformer, which will be kicking off on the 28th of February, 2022. Participants will again come together, but not just on COVID, but on a range of topics, challenges that they are facing and that are most important to them. Now, the Impact Accelerator, which was started in July 2019, we have just finished running the third Impact Accelerator, each time with similar results. The focus is not a training, it's about peers supporting each other, sharing lessons learned, successes, and challenges, and learning from each other, from other countries, from other levels of the health system. What can we do? On the 10th of December, so next in 6 days. 6 days from now, we'll be holding the 4th edition of our quarterly event, Teach to Reach Connect, which is dedicated to networking. Now, Teach to Reach Connect gives you a connection to global immunization leaders. You can see 3 of the ones who spoke in the Teach to Reach conference in January. But you can also see here the quote from Kate O'Brien, who recognizes that the lessons and learning are coming from people who are working in the community. And what that means, this is why she attended this event, to listen to national and subnational immunization staff, the challenges that they are facing. And this is why she accepted the invitation and is very much interested in engaging with participants here. So when they come to Teach to Reach, they're welcomed by the Teach to Reach organizing committee. So 232 alumni of the Teach to Reach program came together to found the organizing committee for Teach to Reach. They are from 35 different countries. So the organizing model, the way we are able to structure, you can think, well, how can you possibly have a committee that has 232 people to organize this? Well, we did, because we had all learned to work through digital networks. And again, to come back to that very personal level, what this enables is the ability to do new things in new ways. Here I am sitting in my living room, and I'm connected with Wasnam Faye Mamesokna, who is a midwife in Senegal, and she has kept me up to date about what is happening with COVID and what she is saying to caregivers to try to reassure them, and what practical steps she's taking to make sure that there are safe conditions for vaccination in her health facility. How else would I meet Wasnam? Where else could I possibly meet her? That is what Teach to Reach is all about. on the 10th of September, the last edition, we had 4,454 people join from 78 countries. Here, I do have to mark a pause and regret that there were 30 participants from India altogether. And I would invite you very much to, there are participants from 78 countries. And if you are listening now and would like to join next Friday or this coming Friday, you are, of course, welcome to do so and encouraged to do so. What is the point? Not only do you have an opportunity to, as this participant said, to dine with the crème de la crème of global health, but you can also see here a very tangible outcome. This is someone who works in a rural area and after Teach to Reach felt empowered to convince people hesitant about COVID-19 vaccine. So finally, we come to Immunization Agenda 2030. Immunization Agenda 2030 is recently adopted by the World Health Assembly. Where we started, the first question we asked was, would this be relevant and meaningful to immunization professionals? Would they care if somebody is working in their facility, in their district at the national level, somebody in Geneva or Seattle or Washington has cooked up a new strategy, so what? So we put that to the test and we organized a global event on immunization challenges. We invited Robin Nandy and Anne Lindström, the two people at the global level accountable at UNICEF and WHO respectively for IA 2030. Not only did they come, but they were profoundly impressed by the strengths of the stories, the challenges faced that immunization professionals from the platform shared during this event. Over 4,700 people registered for the event, 59 global and regional partners. And all we did was we invited participants to share their experience. All we said was, introduce yourself. What's your challenge? Why do you care about this challenge? And it had a profound effect. We saw changes in how people thought about the future of immunization expressed during and after this event. And more concretely, we actually collected 1,847 challenges, which our insights unit then analyzed. And that gave us a picture of what is being faced by immunization staff and what is the gap between now and where we want to be in 2030. I pulled out 3 examples from India. One on vaccine hesitancy due to religious reasons. This is from Vinay Bai. Aishwarya As on reaching migrant communities with immunization services, and Salaj Rana on immunization challenges due to the COVID-19 pandemic. These are just 3 examples, but beyond describing the challenges, what we saw happened, if you think back to Cristina Guerrero and her emergency rescue helicopter, saying she had experienced a change in mindfulness. Well, we see this change in consciousness through this peer learning approach, through these digital health networks in ways that we have never seen them before. Here is a reflection from a participant in Teach to Reach about leadership. Here is a reflection about how we work for vaccine equity. And here is a reflection shared by a participant about the role, the centrality of community and the relationship that health professionals have with communities. So when we think about Immunization Agenda 2030, what we think about today is that on the 10th of December, we will be announcing the launch of the global movement for Immunization Agenda 2030. That for us is a logical next stage, underpinned by the best available learning science and our 6 years of practice in the field of immunization. We feel that, and empowered by the 40,000 now, or almost 40,000 practitioners who are actively working, connecting with each other through our platform, we feel there's a significant opportunity that could not have happened in the past, and that certainly would not be possible without these technologies to support and empower and connect, to work together as a global community with a new kind of consciousness about the significance of change, about the difference each of us can make, whatever level we work at, whether at the most local level or at the highest levels in the Ministry of Health, to connect to each other in new ways, to do new things, but that are actually always about the same goal: improving the health helping, and through better health, improving individuals, families, communities, countries, improve their lives and their future. So that is how we answer this question. What is the future of immunization? And I thank you for your attention. I'm sure I've probably gone way over time. I do want to mention, if you'd like to hear more, there we have a podcast that's at Learning.Foundation podcast, a program to teach our methods and learning approaches, and then again the social media. So that's the podcast, the program, and the social media if you'd like to stay connected and learn more. Thank you very much.
We do not have time for question answers. Okay, because
Yes, sir.
the time is like 1:15 now, so people need to go for lunch maybe. So just one closing comment from the judges maybe. Okay.
So I thank you, Dr. Sadji, for enriching us with your experience, expertise, and motivating us in favor of digitalization, the newer technologies. Hopefully, in your future, definitely all of us or many of us would be meeting you in different platforms as far as possible. Now, I request my co-chairperson, Dr. Provit, who is also an expert here, just share your 2-3 minutes experiences and views.
Thank you. Thank you, Reda. It was an exciting and amazing talk. And I think everybody who has listened to it has enjoyed it. And what we could follow from our IAPSM platform, we can start this networking. Take the initiative of starting the networking, at least here in West Bengal, because we are a West Bengal platform. But definitely we can connect to your network. I was going through your YouTube and podcast, some videos in the morning. And I think the basketball player and the coach, the example you gave, we can act and we can change the role for both basketball player and the coach simultaneously. Sometimes we can be the basketball player, sometimes we can act as the coach. So vertical and horizontal data sharing are different platforms. What you showed from the central level to the down to the field level and across different countries is a really wonderful. I think we will try to get some of the action, whatever you suggested, and implement in the field level and use your knowledge to the best of the immunization in West Bengal as far as practicable. So thank you once again, and probably others can also link to the podcast and YouTube videos of Reda so that they can learn more. Thank you.
Thank you, everybody. Thank you, our respected speaker and the chairpersons. Thank you, Reda, for the wonderful speech. And surely we are going to leave no one behind. Thank you.
Thank you, Shalabdi, for the wonderful moderation. So thank you, Dr. Speakers, Dr. Reda, and the chairpersons also. So you can share the links in the groups, our WhatsApp groups also, so that we can connect with each other. As Dr. Pramit Ghosh also said, we will continue this networking. So we are stopping now for lunch. We shall be meeting sharp at 2 p.m. Sorry, with Dr. Shamima. Yes, with Dr. I think Arup Chakraborty. Okay, Dr. Arup Chakraborty will be starting session on 2 p.m. Okay, thank you.
Thank you, everybody.
Thank you all.
Thank you very much indeed.
Thank you.